So I'm a hematologist and oncologist. So hematologist means specialist is a study of blood. So blood and blood disorders, and oncology is a study of tumors. So onco means tumor and logist means study of.
Yeah. It's like, what is your top 3 or top 5 most common cancers on Guam right now? And is that any different from the stateside?
Yeah, so the top 4 or 5 are...
But also imagine as a, oncologist, it can be quite morbid, right? Like you're dealing with cancer patients. Some will make it, some will not. Like, how do you yourself kind of take care of your psyche? How do you, navigate around like day in, day out where, some patients may not make it, or you're going to have, I'm sure, a few patients that are going to pass away, right? Like, how do you take care of yourself mentally and deal with that kind of stress? Hafade Guam and beyond. This is Dr. Luan Nguyen, the longevity doc. So I am here with Dr. Samir Ambrale. He's the local hematologist, oncologist on Guam. Our podcast is about optimizing mind, body, and relationships. But I also want to talk about some of the health disparities or how we can improve the overall health and condition for Guam. So I want to delve into a little bit about the oncology side and some of the health disparities and things that we could do to improve on Guam. So I thought the perfect person to have was Dr. Samir Ambrale to talk about this and a little bit about his specialty. So Dr. Ambrale is a hematologist and oncologist at the FHP Medical Center and the Guam Memorial Hospital. He's also the principal investigator for the National Community Oncology Research Program under the University of Hawaii, or the Hawaii Minority Underserved NCORP, but he's also the assistant clinical professor at the University of Hawaii and an adjunct associate professor. He has a number of publications, and in terms of education, he studied and finished his medical school at Grant Medical College in Mumbai, India. He finished his Master of Public Health and Epidemiology in Birmingham and did an internal medicine for 3 years at the New York Medical College and an additional 3 years in hematology oncology fellowship in Burlington, Vermont. So a total of 6 years of residence. I didn't realize it was that long. That's a lot of school. That's like basically more than a surgeon or a plastic surgeon. So that's, I would say, one of the longest residencies to just achieve that.
Well, I think there are longer residencies. I think some of the neurosurgery are 7 years.
7 years, yeah.
Yeah, so there are longer residencies.
Yeah, so, before you start, I guess, I wanted to ask, because sometimes I send some of my patients over to you, and they kind of are perplexed, like, why am I sending you to oncologist or cancer doctor? But can you kind of explain briefly what your specialty is and what kind of conditions you treat, and what's your specialty like?
Yeah, firstly, thank you for having me here on your podcast. So I'm a hematologist and oncologist. So hematologist means specialist is a study of blood. So blood and blood disorders, and oncology is a study of tumors. So onco means tumor and logist means study of.
Yeah.
So I've studied blood disorders and tumors and management of cancers, diagnosis and treatment. So as a medical oncologist, I specialize in treating cancers with medications. So a lot of times it is known as chemotherapy.
Yeah.
There are newer treatments now. So in my practice, I see patients a mix of blood disorders and cancers.
Yeah.
So it's about 50-50 population. So sometimes patients get startled when they are sent to an oncologist, but I'm also a hematologist. So a lot of what I do is not cancer also, which is more commonly people will know about anemia as having low red cells, when they have low iron, B12, folic acid. Some older people who get, as we get older, also develop anemia. Also, there are abnormalities of the white cells. So when somebody has a high white blood count, low white blood count, there is another platelet count, which is a particle of a cell called megakaryocyte. So these three are the predominant blood counts that we kind of focus on in a complete blood count test.
Yeah.
So if any of these kind of go up or down in the red zones, then the the primary care physician kind of thinks about what something's going on, and they usually do some initial testing, and if they can't diagnose it, then they send the patient to me to further find out what's happening and something that can be fixed or treated.
Yeah. I didn't realize your percentage of was like almost 50-50 heme to onc. But have you noticed any something that surprised you that's a little more prevalent among the Pacific and Islander on the hematology side? Any blood disorders that I would say is a little more unique compared to maybe the state side?
Yeah, so because of our geography and the mix of populations we have, we do see some of these anemias, which are classified as thalassemias.
Yeah.
Thalassemias, we see some thalassemias, but most of the time what we see are thalassemia traits.
Yeah.
So thalassemia is a disorder of production of the protein part of the red cell, which is called hemoglobin. So if there are defects in those chains, then somebody can get thalassemia. If there is not very serious defects, somebody gets what we call a trait, where they have a little bit of abnormality, but most of the time they don't have any symptoms. So their hemoglobin tends to kind of run lower than normal, but usually it's nothing that needs to be corrected or should be corrected. A lot of these patients tend to be put on iron a lot of times for a long time, and then when we see them, we kind of go over their blood test and their ancestry. So a lot of these patients are from Southeast Asia. So we see a lot of patients who are Filipinos. It's quite common in Filipinos to have thalassemia traits. So we see those. We also see a lot of patients who have elevated ferritin levels.
Yeah, I send you a lot of those. Sorry.
Yeah, so that's it's a very ambiguous part of hematology. But most of the ferritins that we see, or ferritin is a type of a storage ion. So it is also what we call acute phase reactant. So it goes up in conditions which causes inflammation in the body. So any kind of pneumonias, colitis can cause ferritin elevations to go up, but usually they will come back down. The body has a very good mechanism of managing the total iron in the blood and in the organs. But sometimes when there is inflammation, and the most commonly we see is metabolic syndrome. So metabolic syndrome causes low-level inflammation throughout the organs, and it can cause increase in ferritin levels. So we see a lot of patients who have ferritins above normal, so above level of 400 to anywhere between 800 to 1,000. And usually we will test them for some of the genetic tests that we do for something that is called hereditary hemochromatosis, where there is a defect in the channels that absorb iron. So these defects can cause the iron absorption to turn on all the time, so the body doesn't know how to turn it off. So they keep absorbing iron, and they can accumulate iron.
So you're saying that, so just for the audience, metabolic syndrome is kind of in this broad category of people that have diabetes, obesity, hypertension, those kind of, I would say, inflammatory disorders, and that in itself can elevate the ferritin or inflammation levels. And so in these population, you normally wouldn't see like a ferritin above 1,000. Is it usually
It's very atypical to see about 1,000. If there is about 1,000, there is something else might be going on, or it's acutely inflamed and usually will come back down. There are conditions where we see higher than 1,000, where patients who are on dialysis. So these patients are chronically anemic because the kidneys don't work, and kidneys release a hormone called erythropoietin, which is needed for the bone marrow to get stimulated and make red cells. So these patients, because they're anemic, they are getting external erythropoietin through injections. And to make sure there is enough iron, they get periodic iron infusions. And it's important, but it also causes the ferritin to go up because it kind of builds up.
So when I send you patients that are ferritin in the 800s, you don't freak out. It's made if they're more metabolic syndrome related. Like sometimes I worry though, like, is there anything to do with a ferritin 800? Because I worry that even at the level of 800, there may be some end organ damage, like liver damage or heart damage from that ferritin. Like, is there anything to do about that, or like, is it even worth doing the traditional blood draws to remove the ferritin and the iron?
Yeah, usually not. So we think about on end organ damage really will start about floating about 1,000, well about 1,000 rather. But if it is not below 1,000, we don't really recommend any other specific testing, like any MRI to quantify the liver iron or liver biopsies. How about 1,000? Yes, if we don't have any other any other reason that could be causing ferritin elevation, then we do the MRI to quantify the iron.
Yeah.
But the gold standard is to do a liver biopsy,
Okay.
which can quantify the milligrams of iron per gram.
Does elevated liver function tests, or those kind of the signs of liver damage in the blood, your AST, LT, is that any indication for you to, treat? Or do you still fall
not
back
per
on
se.
the...
We still have to fall back on the iron, the liver iron. That's usually the indicator to do something. Because a lot of patients with metabolic syndrome will have fatty liver or non-alcoholic steatohepatitis. We call. So they might have minor elevations of AST/ALT due to that. But if they don't have any significant iron deposition in the liver, we don't really treat those.
Okay. All right, good to know. So, and falling back up to the thalassemias, so it's somewhat common in Pacific Islanders, Asian, or Filipinos. Are there situations where you can have a thalassemia? Oftentimes the thalassemias, your hemoglobin might be low, right? But it's kind of minor. Usually it's in like at the 10 level. Is that right?
For the traits, it tends to be between 10, 11. Some traits, it can run between 8 to 10.
Okay.
Yeah.
But is there anything to do, or is there any treatment if it starts falling in the 8 range, or still you leave that alone?
Yeah, so usually they will have a pretty basic, we will know what the trend is. So if you look at if you have enough lab over the last 2-3 years, you know what their baseline is.
Yeah.
So usually their baseline is there, and they have, say, alpha thalassemia. Alpha thalassemia is usually one of the most mildest ones, so they tend to be between 10 and 11. A lot of them are women, so 10 and 11 is not very different from the 12 and above. So once we know their level is, know the baseline, if they go below the baseline, then we kind of think about what else could be happening. A lot of times they can be vitamin B12 or folic acid deficient. Sometimes if they're older, in their 60s, 70s, we think about bone marrow failure syndromes like myelodysplasia, where the bone marrow kind of gets older, cannot make red cells effectively. So most of the patients I recommend to at least take a multivitamin or a folic acid a day to make sure they have enough folic acid, because that's kind of gets turned over into production of the red cells.
Okay. All right. I think we got pretty technical off the bat, pretty nerdy here. Yeah, and for your information,
well, I can talk about this.
When I was studying for my boards in USMLE, usually like I'd kind of just skip the hematology questions because those are so hard. And if I saw a biostat question or a hematology question, I just picked C and just moved on. It wasn't worth my brain power to try learn all that stuff because it's so complicated. So I wanted to get into maybe some more of the more general questions that maybe not as technical maybe, but maybe what some patients would be interested in. But I was wondering, on Guam, what are the most, I guess, say, prevalent cancers? Like, what is your top 3 or top 5 most common cancers on Guam right now? And is that any different from the stateside?
Yeah, so the top 4 or 5 are breast cancer, lung cancer, colon cancer, prostate, and kind of uterine. So yeah, breast cancer is the most common that we see.
Yeah.
A lot of patients we see with breast cancer. I think it also has to do with that we have very good screening tests for those.
Yeah.
And we have good in radiology places in Guam to do the screening test. There are programs from the public health to offer free screenings for women above 40 to do mammograms and the ultrasounds and whatever needs to be diagnosis-wise. So those are the breast cancer is the highest one. Lung cancer comes next because of the smoking. we lung cancer also has the highest deaths in Guam. So people die more of lung cancer than breast cancer because lung cancer we see here are presenting usually at a stage 3 or stage 4. So late stages, so they have harder treatments and they have shorter lifespan.
Yeah.
Breast cancers, what we see are most of the time overwhelmingly 85-90% are early detected. So they are most of them are stage 1, stage 2 that can be treated with a curative intent. So we treat them with multidisciplinary treatment, so surgery, chemo, radiation, hormone therapies. So they do very well.
And, in terms of prostate cancer, some of the guidelines we get as family medicine is don't even test PSAs. But like, I personally test PSAs. But what's your kind of thoughts on the guidelines for checking the PSA?
Yeah, the guidelines are all over the place, but
Yeah.
I mean, they talk about mutual shared decision making between patients above 55. Yes, definitely. You also think about family history. There is a family history of prostate cancer, breast cancer, ovarian, uterine. If these cancers are there in your family, you might be at higher risk because there are certain familiar syndromes that are associated with, like BRCA2 mutation can cause prostate cancer risk increase. So that's one thing. The other question is, at what level of PSA would you kind of think about doing something?
Yeah.
Because prostate cancer, as you know, is a fairly slow-growing cancer. So PSA will rise, it goes abnormal, and at some point we have to do something. And at the level of primary care physician, they don't know anything that goes red. We get kind of scared, and the patient gets anxious.
Yeah. At what level would you say? Because the cutoff is right around the PSA, the prostate specific antigen levels are usually around 5-6, right?
Right.
As an oncologist, like what numbers kind of like red flag? Oh, this is probably a little bit more dangerous cancer that needs to be something done. That's kind of a loaded question, but ballpark, what would you say?
Yeah, we don't look at an absolute value. We always look at how fast it's.
So it's more the delta of how fast it's rising.
Yeah,
Okay.
usually what we look at how in 6 to 12 months is it really going is it kind of getting doubled or close to double? That's something we need to work on quickly. But usually anything about 10 to 20, without any history of prostatitis, then prostatitis rather, then something needs to be kind of done to kind of work up. So you need to talk to the patient, say, this is a prostate cancer. You might have prostate, this is probably prostate cancer. There are options to diagnose and treat it. And then would you like to do, most patients will say yes.
Yeah.
Also to look at their age. So, as most people, most men above, at one point, if we live long enough, we'll all get prostate cancer.
Yeah.
So if they're in their 80s, higher 80s, then we really have to have a discussion about really do you need to do a lot of workup, biopsies, and put them through radiation and stuff. So it's a shared decision making for that reason.
Do you tend to see any correlation between the PSA levels and symptomology? Like, just the typical symptoms of prostate enlargement is, a little harder to strain to pee or peeing a lot at night, those kind of symptoms. Like, do you find any correlation or?
No, you'll have a prostate patient with benign prostatic hyperplasia and will have those symptoms too. You'll have a patient with PSA 100 and have the same symptoms and nothing else. So by itself, the PSA number doesn't tell us about symptoms. Most patients will not have any symptoms till either they have bone mets or they start having what we call parenchymal disease. So they have lymph node swelling, lung mets, they start losing weight. So the most common symptoms for metastasis is bone. So they firstly look at the bones, and then patients start having back pain. That's what they present.
Okay. So we'll stick on the topic of cancer, but you mentioned the top cancers on Guam, but looking at cancer, would you say there's some common causes or some modified risk factor, whether modified or not? Are there some common causes for cancer?
Yeah, we know there are causes of cancer. We can divide them broadly into multiple kind of broad categories.
Yeah.
One of them is environmental. So UV radiation is one, radon from the ground. Then there is these chemical exposure. So a lot of it, there is a huge list of possible carcinogens on the, if you go to the American Cancer Society website,
Yeah.
there's a bunch of it, but most commonly we'll see, benzene used to be used quite often, silica dust, asbestos, those are the ones, and then there is chemicals in smoking, so
Yeah.
tobacco smoking, betel nut, so betel nut is a known carcinogen. Then there are these infectious diseases, so hepatitis B, hepatitis C can cause cancer of the liver. Then you have HPV, so human papillomavirus can cause cervical cancer in women. It can also cause cancer of the oropharynx, the oral cavity pharynx. So head and neck cancers. Then there is Epstein-Barr virus, can cause cancer of the nasopharynx.
Yeah.
And then there is, patient-specific. So obesity is also one of the reasons it can lead to cancer. So there are cancers associated with obesity. Most of them are related to metabolic syndrome and chronic inflammation. And there are certain cancers which are heritable, so they are passed on because of there are damages to genes that kind of help fix carcinogens, so,
Yeah.
or the cancer-causing genes. So some of these genes are passed on defective from either parent, and they can cause a bunch of cancer syndromes. So
Yeah.
those are the, and then most of the overwhelming majority of cancers are just bad luck.
So, yeah, going back to breast cancer, you said obesity, metabolic syndrome, I guess genetics. Is there anything else that comes to your mind that might be at least a modifiable risk factor, you think, for breast cancer?
Obesity is one of the modifiable risk factors. So obesity, postmenopausal women, there is a link between obesity and breast cancer. Use of hormone replacement therapy. Also, it may not be modifiable, but having a prolonged period without interruption of your hormone, estrogen. So women who have early menarche or get periods early, have late menopause, so their body's exposed, breast tissue is exposed to estrogen for a long time. Having no children or nulliparity is one. So those are the risk factors are in women, in younger women.
Okay. What about colon cancer? I heard one thing is like having too much charred meats. Anything else that's a little bit more specific for colon cancer compared to other
So
cancers?
colon cancer also, some of them are related to, hereditary cancers. So we have Lynch syndrome, hereditary non-polyposis cancers. Then there is smoked meats, processed meats, consuming red meat, processed meats multiple times a week. And apart from that, I'm not sure there is more.
So we kind of covered some of the modifier risk factors.
It's about the inflammatory bowel disorders can increase risk. Yeah.
Yeah. So this kind of maybe ties into the question of how that happens in terms of metabolic syndrome. But, one of the things, if you go on on the YouTube, one of the key phrases you might hear is that cancer is a very highly metabolic cell, very energy dependent or glucose dependent. So, some influencers might say a ketogenic type diet might be helpful to starve off the cancer, but how would you attribute, how true is that?
That's not true. Sugar is bad in general, but it's not bad in specific for cancer. So we don't recommend any special diet. We actually recommend them to eat whatever they can, whatever they feel like. Obviously, try to be healthy if possible, but at some point when somebody gets cancer, the opportunity to prevent cancer has been gone. So, if you had 20 years to kind of prevent that, 20 years ago was a time to modify a diet. But when you are actually got diagnosed with cancer And if you need, especially if you need to go through therapies, that can be hard. Your appetite goes down. We don't want them to limit their diets because there is no solid reason to or data to say a low or completely removing glucose or carbohydrates from your diet will help slow down the cancer significantly. So we recommend them to have a normal diet. That's pretty much it.
Okay. But maybe a less inflammatory diet. I mean, at least less processed foods, right?
I mean, that's a recommendation for everybody.
Yeah.
But that level goes down in patients who are on chemo. So I don't. If they like to have a steak here and there, I'm like, sure, I'll have it.
Okay.
That's something that keeps your weight up. Yeah.
Yeah. And another thing I've heard, and these are anecdotal things, but is there any key associations between some sort of emotional trauma or just maybe the kind of, what do you call it, the midlife crisis where they've hold on to a negative emotion for so long and that kind of incited cancer, and once they resolved that, the cancer went away? How much is that a myth, or what's your thoughts on the emotional aspect of things?
I don't think I've seen any evidence to say that de-stressing will help or detoxifying will help reduce cancer or make it go away. So, yeah.
So no evidence there.
No evidence there.
Okay.
Evidence or personal experience or patient experience with that.
Oh, that reminds me. You talked about radon. I never even thought about that in terms of etiology of cancer, because I know there's some radon up more towards Dededo.
Yeah, there is radon.
Have you linked any cancers on Guam with that personally?
I mean, it's hard to say. I mean, Dededo is the most populous village in Guam,
right?
So you're gonna have some link there, but I mean, somebody has to do a study to actually.
Okay, but you haven't gone out like this person has 0 risk factors, super healthy, and has cancer at a young age, and there's nothing else. So they got their house tested for radon. Like, you never went that far to find out an etiology. No. Okay. All right.
Yeah. I mean, that would be. I mean, if you do 1 or 2 things, it would be an anecdote. But to actually prove something, you would need an actual decently good study to do that.
So, we went over some of the most common, cancers on Guam, some of the risk factors and some of the modified risk factors that you can do to maybe prevent or also improve potentially the outcomes. We dispelled some myths. Now I want to get to some of the realities on Guam, right? As a hematologist, oncologist on Guam, and you're like one of 2 on Guam, which is sad. We need more because you're just booked to the 9, and it's hard to get to see you now. But what are the issues you're facing with medical insurance when you're screening, treating cancer here on Guam?
Yeah, big question. Sensitive question also. So it all comes down to the cost of healthcare, right? So we all know healthcare costs are going up. Cancer costs are going up even more because of the drugs that are, the newer drugs are more expensive. So there's 2 things to it. One is the question about the underinsured or uninsured. So they have the probably has the highest morbidity and mortality from cancer. So underinsured, uninsured, they don't have enough. They don't have insurance, or they have minimal insurance, basic, which does preventative, maintenance kind of thing. So they are not getting screened. They don't get screened. They might have access to it, but they are not doing it. And there's a couple of reasons to it. First of all is the part of the insurance called deductible. So most of the insurance plans will have some deductible. So deductible is a payment. So you pay your premiums. So you pay money to the insurance company.
Every paycheck you get deducted.
Paycheck you get deducted a little amount.
Somewhere maybe around $30 to $100, depending on single versus family. But somewhere around that range, you get deducted in. So, but if you are, like you said, the low insured or high deductible plan, you might pay less of a premium every paycheck, but then you'll have a higher deductible where you have to pay a lot of upfront before the insurance really kicks in, right? Okay.
Yeah. So when they're paying the premium, so you're paying one time, and then you have the deductible. So say if somebody has a $1,500 deductible, so they have to, for using their insurance, they have to pay at least $1,500 before the insurance can be used to pay for something that is covered. So most families find it hard to even cover the $1,500.
Yeah.
And then after they hit the $1,500, they assume it'll be covered, but they still have a copay.
Right.
A lot of times, which is could be 80%, or they have copays of physicians. So the copay is they pay 20% of the whatever the charges are. So physician charges, imaging lab charges, medical.
So if the total bill, say from the doctor's visit's $100, you'll still be responsible for $100. If you have an MRI, that's $1,000. That'll be $200, right? Yep.
Yeah. So they pay that, and then that goes towards what is called the out-of-pocket maximum. So there is out-of-pocket is basically till you once you hit the deductible, you pay 20% of the cost till you meet your out-of-pocket, and it could be different from different plans. So once you hit that out-of-pocket, which could be $5,000 or $8,000, then the insurance is supposed to cover pretty much everything that is in the statement of benefits. So that's the main thing is families should plan to have that deductible as a emergency fund stored away and not touched. So if it's $1,500 is usually for one person, for families it could be more. But you should look at your deductible and say, okay, I want to put away this deductible for my myself or my family. So if I need to, at least I have that money to use towards it. And then be ready to have the out-of-pocket if there is a major medical issue. You're going to hit that $5,000 pretty easily, especially if you get hospitalized.
Yeah.
So you should have funds to kind of plan to have funds to use that to out-of-pocket.
Yeah.
So that's the major thing that we talk to our patients is to prepare financially, understand their insurance, the benefits, read their actually statement of benefits, schedule of benefits that is given to them every year.
Yeah.
And we actually, me and my team actually look through these benefits on a kind of a weekly manner because we always, have to deal with denials. Of some sort.
Yeah. Yeah.
So, one part of the doctors, as you also know, role is to not only treat but also kind of advocate for your patients, is to say, negotiate with the insurance, make sure the patient understands what their rights are, understand the insurance, and if it is if there is a issue, if there is it's a difference in interpretation, then we contact the insurance company and say, this is what it is. Should be can you kind of help and advocate for the patients?
Okay. Some sage advice from Dr. Ambrale, and to have extra savings up for having enough money for the deductible. But it's a sad story because a lot of the patients might think they're covered, right? They're paying their premiums, they got insurance, but they think, if they had the unfortunate incident of having cancer, that their chemo and the radiation is covered. But you've had patients that couldn't afford, or they couldn't get the chemo because they couldn't afford it, right?
Well, there are instances where they are not able to afford, but we have some of the non-government organizations like Guam Cancer Care. There is the Carlo Foundation that were giving them grants, so they are monetary grants.
Yeah.
So they get assistance from that. There are also possibilities of getting some pharmaceutical co-payment cards. So some of these off-island specialty drugs we use, oral therapies, they have high costs, and some of these are not covered. They might be covered 50% of the price or 80% of the price, which
Yeah.
is still pretty phenomenal for anybody to pay, which could be anywhere between 3,000 to 4,000 a month.
Yeah.
So there are some copay assistance available through the pharmaceuticals foundation. So we use those. But yeah, there sometimes we'll have to change treatments because obviously the recommended treatment is not something the patient can afford. So we'll have to go to alternatives. There are also times where the insurance companies will say, okay, you cannot use this. You probably heard about it, the step therapy. So they have to use this before you go to the next kind of step treatment.
Yeah.
It's like using gabapentin before using Lyrica.
Lyrica, right. But that's sucks if you can't use optimal treatment up front because, this is different from stepping up from metformin and the glyburide. Like, you want to do chemo once, right? Or you want to do something treatment one round, not too much exposure, and do the optimal treatment up front, right?
Yeah.
So
yeah,
that,
and a lot of times it comes down to the cost, right? So
yeah.
say the first frontline treatment is obviously newer, more expensive, and the second line treatment, which some insurance might cover, is less expensive. So that they have that savings, cost savings if they make us use a second line. But a lot of these drugs that we use, most of them are fairly well priced these days. So there is no onus on trying to save anything because the first line, second line are pretty much the same cost. So that's why when we go appeal to the insurance company saying this is what is recommended, and then they will usually listen to us and approve those.
Okay. Like, about what percentage of the, I guess, treatment plans or PAs you put in get denied, would you say?
None of them will get denied per se.
Yeah.
They might get modified. So whatever we put in is medically necessary. So
Yeah.
they will not be denied for that. They might be denied saying this is non-formulary
Yeah.
or non-preferred medication. So they will say, okay, it's a non-formulary medicine. They will pay 20% or 50%, and the rest is the patient's cost. And that's still pretty much pretty big amount for them to pay anyways. So we'll go and appeal to them again, and sometimes they will listen. So usually, advocating for the patients, will meet somewhere in between, which is something that the patient can manage.
Yeah. And like, if you had a magic wand or were able to advise, certain agencies like Guam or any company when they're picking out an insurance plan, like, is there a message you wanted to put out, like how for better coverage, or like, I think we talked about this before privately, but
yeah, I mean, obviously the companies should listen to their members. So like, most of the private insurance plans are sold by employers, right?
Yeah.
So the employers will put in money and then the employee puts in. And the plan that a company will pick will depend on obviously the cost, right?
Yeah.
So companies want to make sure their employees have insurance, but they also want to keep the cost down for themselves and the insurances. So that's one thing they have to look at is, what's your mix of your employees. If you have older employees, you might need better plans to make sure your employees are covered, adequately insured.
yeah.
Bigger companies definitely have more leverage. They have a bigger bucket to kind of fund these plans. So listen to your members or employees, and the other thing that sometimes we can talk about is the need of having, for cancer purpose, having a cancer rider or add-on policy, and people have the option of buying it. And so you obviously pay more, but if you get affected with cancer, you have a better insurance than what you would otherwise have.
So it's kind of like adding an AFLAC, but for example, with Select Care or Net Care, do they have rider
No,
additions?
nobody has a rider on
Okay.
this yet. So it's all part of one policy. So that should be something that they should think about, is having an option to have a a better insurance. If somebody has proactively manage their finances or want to get a better policy, they should be able to have that.
Yeah.
Also listening to members about the complaints. So if the patients are having hard time, paying because the formulary is restrictive, or they're not getting the treatments they want on the island, because we have a small island, so we don't have the bargaining power to same as a bigger hospital in the mainland. So we pick drugs that we keep in Guam that are easily available and cheaper, also, right? So if the company says no, this is our preferred brand, and you can only use this brand, and we say we cannot source it. Like today we had a case, we have a company saying, okay, this is our preferred medication, and we as a clinic, we don't have access to it. Our vendors can't bring it to Guam. So we are like, okay, what can we do in that case? Can you give us an exception and send this medicine that we have in stock? We can use it. Otherwise, the patient's treatment is going to be delayed, or they have to go to another place where they might have it, which probably going to be off island. So we engage in dialogue with the representatives of the insurance company, and most of the times we will find a way.
Okay. Any other frustrations and that you wanted to get out there? I know
it's not frustration. These
Yeah,
are,
yeah.
I think these are just part of healthcare that we have to talk about. And I find that the way to get around things is just having openly communicating with all the parties, keeping the patients informed, talking to the insurances. So we are healthcare involves clinics, hospitals, insurance companies, patients. So everybody has to talk to each other to make sure we all kind of get on one page.
Yeah. I mean, one thing that comes to my mind, which is crazy, is some of the most expensive treatments are the immunosuppressives or the chemotherapy agents, oncology medicines, right? Like, we're talking like 3,000, 4,000, even 10,000 a month sometimes for these medications.
Some of them like 14,000 a month.
This is ridiculous.
Retail.
Like, that's a mind-blowing number, right? Like, why are these medications, like, why are these particular class of medications so much more expensive than, say, other medications like Ozempic or even Ozempic, right? Why is there such a big gap in price?
Because the companies set their prices and the U.S. Congress cannot negotiate it. The CMS, Center for Medicaid Services, cannot negotiate these prices. So it's a free market.
Are other countries negotiating lower prices?
Yeah.
Okay.
Yeah, so the European agency that approves drugs in Europe, they can negotiate prices.
So can you give me an example of what that negotiation, like how much of a price
I don't have the exact prices, but Europe can negotiate drug prices, which is significantly lower than what we would pay.
And what percentage of medications, general pharmaceuticals, or even like chemo medications are produced by U.S. companies, would you say, or would you know that figure?
Most of the drugs are produced by U.S. companies.
Most drugs are
yeah.
So that's the craziest thing to me. Like, we, the United States, make the most, or it's our companies that make the most of the pharmaceuticals, but we charge ourselves the most. That's just mind-blowing to me. That's just crazy.
This is the free market economy. Yes.
I don't feel like it's a free market.
Well, they set their prices, and the government cannot negotiate with it.
Or why do you say you cannot? Like, I don't understand that. Why can't? Well, other governments or other entities
because Medicare does not have the authority to negotiate prices, set prices for drugs.
That's interesting. And
because the prices are set by, everything we do is like in private practice. All our rates are based on Medicare rates, right? So our consultation rates, for example. So the Medicare sets a fee schedule, and then we have to accept it if we accept Medicare.
Yeah.
But the insurances also go by the Medicare rates. So the insurance will say, okay, Medicare is paying you, $10 for a particular service. We want our patients to come to you. We'll give you $12 for the same service. So the insurances will use Medicare as a baseline to use that as their tool for reimbursement. So it's all set up through the Medicare.
Yeah. Yeah. Pretty interesting how pharmaceutical rates, not very negotiable, but reimbursements to physicians tend to drop year after year, or services drop.
Yeah, and you would think that, especially in oncology, when when a drug goes off patent, other companies can make it. You would think the prices will go down significantly, but they don't.
Yeah.
They're still quite high.
Yeah.
They're cheaper than when it comes out first, but it's not significantly cheaper.
Okay. Yeah. Any other maybe suggestions for insurance companies, patients? I guess maybe even in general, not just even on the oncology side. For our island, do you think there's anything that could be done more efficiently, and any advice that to improve healthcare delivery and maybe improve incidence of cancer and chronic illnesses on Guam?
Yeah, I mean, each of us has a responsibility to be healthy, right? So first of all, healthcare starts with you. So you want to do whatever you can to minimize your risk of getting chronic disease or cancer. So obviously having a active lifestyle, eating healthy. Eating healthy is not cheap in Guam. Eating unhealthy is cheaper, actually. So buying, processed meats is cheaper than buying fresh vegetables. Access to fresh vegetables, fruits. If you go to the store, you will see vegetables and fruits are very expensive, and you could fill a bucket with processed meats and red meat. Then you could buy a whole month of groceries. So
Yeah.
so it's hard, but you have to find a balance. So eat healthy, do some physical activity every week. Don't smoke, minimize alcohol or no alcohol. And then look at your insurance policies. Make sure you have some financial emergency funds put away to use that as deductibles.
Yeah. On smoking, right? I mean, I think at this point there's enough of a marketing campaign that everyone knows that cigarette smoking is highly attributed for lung cancer, right, or some other cancers as well. But what's your thoughts on vaping? Is there any link with vaping and lung disease or cancer?
Well, I've seen some reports about lung injury from vaping, but I don't think there is enough evidence yet to show there is increased risk. I've seen because it's still the data is still young. Usually, you need exposure to like smoking. You need 20, 30 years sometimes to see if there is increased risk, to have strong enough data to say for sure.
Yeah. And what is it in the cigarette that leads to lung cancer, or how much does nicotine in the cigarette have any part in cancer, or is it all the other stuff?
It's the other stuff. So nicotine is not a carcinogen, but it's an addictive substance, so that makes you crave smoking. So the other stuff is the tar, the chemicals that are burnt, that are carcinogens in cigarette smoking.
Okay. So, I think one of the reasons I like family medicine is, and I don't necessarily have a desire to work in the hospital because it's just very acute, it's too stressful for me. But also imagine as a oncologist, it can be quite morbid, right? Like you're dealing with cancer patients. Some will make it, some will not. Like, how do you yourself kind of take care of your psyche? How do you navigate around day in, day out where some patients may not make it, or you're gonna have, I'm sure, a few patients that are gonna pass away, right? Like, how do you take care of yourself mentally and deal with that kind of stress?
Yeah, it is hard, as an oncologist, because we see the patient at diagnosis, and then we see them pretty often. We see them a lot of times every 2 to 3 weeks when they're on treatment. So we get to know them very well. Their families a lot of times come, and we get to know the families also. So it's it's hard when things are not working out, but our relationship is based on honesty. So we are the first consult, we when we talk to patients, we tell them we will be very honest with you about what your cancer is, and at every step if there is a change, we will be honestly tell you what that change means, and if it's gonna significantly kind of affect your survival or life expectancy from there. So the patients are constantly informed about that, but he also celebrates the victories. A lot of patients get cured, and the scans are good. So we like those visits. But yes, some visits are hard where we have to tell them about the cancer is progressing, the scans don't look good. We'll have to stop this treatment, go to a different treatment. So those are hard appointments. And obviously, sometimes we will lose patients from cancer. But I think, for myself, I think the part that gets me through is being honest to patients. Using evidence-based medicine. I know that I'm doing my best for the patient in their treatment, picking the regimens. Making sure their symptoms are taken care of. We have an excellent team at FHP, so. A nurse practitioner, nurses, medical assistants, all are very involved in patient care and taking care of their needs. So we know that we are giving our best to the patients, and we know that at some point this is not going to work. And also I've learned that to leave work at work. So I don't think about. I wouldn't say not think about it, but I don't dwell on it a lot of times. I will think about some patients sometimes, when I'm just sitting around, but it's not. I usually like to shut off most of the times when I leave work, so I can focus
on family.
Family.
Yeah.
Yeah, it is not something. I mean, it just comes as it's an occupational thing. You have to learn to live with it.
Yeah. So I don't know. I don't think my heart or my mind could take it if in the hospital seeing death after death, like that's I think part of the reason why I don't necessarily like to be in the hospital, because there's a higher chance. There's a lot of obviously success stories and people get discharged.
Yeah, I mean we don't see death very often.
Yeah.
Things have changed quite a lot since the last 15 years. So yes, we will have patients who die, but most of our patients don't die in the hospital. So we can see when they are declining, we talk to them about, hey, this is getting, you're declining. We don't think the next treatment is going to help you. Let's talk about just doing, best supportive care, helping your symptoms. Talk to them about hospice. Give them a very realistic kind of time frame. And most of our patients are, when somebody's going through cancer treatments, they know it's hard, and when they know that the next treatment may not work, they want to have the highest quality of life. So want to stay home, not go to unnecessary hospital or emergency visits, not do unnecessary medications, lab draws. So studies have shown that patients who go on hospice care towards end of life, they have better quality of life. They actually tend to live longer than patients who pursue chemo treatments till end of life. So we try to get them towards palliative care, hospice, and most patients will pass at home with their friends, relatives, family members next to them.
So there's new, and it seems like there's some exciting things coming out with cancer treatments now, like immunotherapy, some of the drugs that are targeting blood vessels, because that's also a big key in terms of cancer growth, right? If there's an environment for blood vessels to reach the cancer cells, that's where they really exponentially propagate, right? And there are newer drugs to target that. Is that correct?
Yeah, so there are these drugs to target inhibit new vessel growth. There are a bunch of them. Some of them are IV. Some of them are like oral. They call tyrosine kinase inhibitors, VEGF inhibitors, So there are, these have been available for 10, 15 years. There are newer ones that are keep coming, targeting different types of cancers, different points where cancer or carcinogenesis happens in the pathways, biochemistry. So, and there is immunotherapy, which is a relatively newer, probably 10-year-old treatment approved now, which kind of helps your body's immune system to find and kill cancer cells better.
Yeah.
So these are immunotherapy as by itself is, I mean, we like to use it because it works, and we can see some markers from the the tumors that tell us that this immunotherapy is more likely to be beneficial. So those patients, we are kind of looking forward to seeing their tumors kind of shrink, go away. So, and these treatments, immunotherapies, don't have a lot of side effects like chemo. They have some rare serious side effects, but per se, day-to-day life, patients don't have any symptoms.
Yeah.
They do very well. Some patients who respond well, I've seen their cancers completely go away when they were stage 4. So, yeah, people have been cured with immunotherapy.
Yeah. And so I think there's some exciting things coming out the way for cancer treatment. It's going to get better and better, and I'm hopeful for that. And I think where I have to be better, somehow the system has to be better, is on the preventative side. Is you're saying a lot of the metabolic syndrome is a big driver for that. So we as a society have to do better on improving the metabolic syndrome and the diabetes rates, right? The last thing I want to end with is I think it's important for a lot of the people on Guam, or employers or senators or people that want better for Guam, to hear another perspective, how to keep professionals on Guam, right? Because you're not a Guam person. I'm born and raised in Guam, so there's a higher chance that I would come back here and serve the people of Guam. But you came here almost 9 years ago, right? Or 10, close to 10 years ago.
This is the 10th year going
and
on.
It's crazy. And you just got your U.S. citizenship, which is awesome. But I think it's important to hear, like, what attracted you to Guam and why? Because a lot of people, especially people that go through I'm not going to pick on GRMC, but just in general, a lot of the doctors that come from stateside come and go in a year or two, right? But what brought you here and what kept you here so far?
So what brought me here was the job at FHP. So I came here straight out of my fellowship. So that was 2016. I was at University of Vermont finishing up my fellowship. So I was approached by FHP. So Brenda Sana from FHP, she was a manager there. She got in touch with me through a recruiter, and I wasn't even thinking about Guam. So I did my fellowship, residency and fellowship on a J1 visa, which is an exchange visitor visa. So I had to look for a place that would sponsor a J1 waiver, which converts into a H1B visa. So these jobs are fair and few in between, especially for specialists. So I got a few interviews in rural places in the mainland. So I was looking at that. I interviewed at those places, and then a recruiter called me to say, okay, we have a job in Guam, and they want to interview you. So I interviewed. I looked it up, Guam. I knew it was in the Pacific, but did some more research, and then we did a Zoom interview, Skype interview in those days, and they offered me a position. So I said, thank you, but I would like to come and do a site visit, which is usually the way interviews work. So they brought me out here, toured the clinic, met a few other doctors, and my wife Joy was pregnant, so she couldn't come with us, accompany me. So we went back and talked to her and told her, it's a good place. They had a good package for us, relocation and 3 years contract. And we looked at our options, put it on paper, did pros and cons of each of them.
Right.
And then we said, okay, Guam looks better, is looking, a top runner. Uh, and we said it will be an adventure to, we've never had, lived outside a big continent.
Yeah.
So we decided to jump in and started working. And what kept us here was the community that we built, the community that assimilated, took us in. The first was like, I think tennis was our first thing that kind of we built friends in Guam. So playing tennis, both of us join and play tennis. So we built a lot of good lasting friendships since then. And then, kids school, we made more friends. So just the Guam community, once you get in there and you stay, and they will embrace you, right? We know that now. Our kids are born. One of the kids is born here, but for our kids, this is home. They don't want to go anywhere else. So every time we go out somewhere, go to see their grandparents, they don't want to stay that long. They want to come back. And
even with all the glimmer and lights of New York City
and all the good places they can eat and go to
they still
parks and
want
all
to
that.
come back to Guam.
They want to come back. Their friends are here.
Okay.
So yeah, the community kept us in. The need, we know that I'm the only longest. Dr. Friedman was here, but I'm the only one now here, which is permanent oncologist. So, there is a need, and we have good collaborators with the surgeons, primary physicians. We have good rapport with all of them. We've been working with the University of Hawaii to do some clinical trials. It's still very early, but we are, working with them, the OG also. So we're kind of, I'm involved enough that, I feel like this is this is good.
Okay. Yeah. So the community kept you here, the hospitality of Guam.
The Hafaday spirit.
The Hafaday spirit. And so listen up on how to retain the physicians and great doctors like Dr. Ambrale here on Guam. Me personally, and we're probably, we all have the same goals or concerns, right? And I think one thing I do want to push in is we're here to raise our kids and we want a safe environment. So if there's anything that would maybe even push us out of Guam is, the crime rates, the level of safety. So I think that's one thing to really consider for Guam security, police department, anything like that, to make sure our kids are safe.
That's right. You're right. In the last, since pandemic, we've seen things declining, right? I mean, our public infrastructure is not the best. We still have power outages. Our public hospital is always in disrepair. Schools are always in trouble. So the way we would attract new healthcare professionals is to obviously, pay them more than what they would get paid in mainland. Because obviously the cost of living here is higher, significantly higher than even the biggest, I won't say the biggest, but majority of, tier 2 cities in the mainland. Food is expensive, traveling from here is expensive. So the most important thing to bring somebody on here is to offer a good salary that is quite a bit higher. And once they are here, hopefully the Hafaday spirit will keep them here. But yes, seeing all these news about, the infrastructure going down is not going to help.
Because, something just dawned on me the other day where GMH is the only pediatric hospital. And
in this region.
If it gets shut down, like there's a fire or there's no supplies, that kind of scares the hell out of me. Like if my kid gets injured and they can't get treated at the hospital, only in one hospital that takes in pediatric patients. So that would be a big concern for me, and that's what I'm looking out for too. So, that's the message I want to set out. We got to have a hospital that can take care of our kids. So
and the thing that I would think also, I mean, if somebody's watching from the lawmakers, is to have a backup plan if one of the units has to be shut down, if the roof collapses or some major fire breaks out, you need to have a backup plan where you can swiftly, like tent city, we had that back in COVID, people can get treated in tent temporarily, but there has to be a plan B where if a complete unit goes down, we need to have some space where you can take care of, say, pediatrics.
Yeah.
So because we'll have the doctors, we can get the other supplies, but we need a physical space to kind of deliver that care. So I'm hoping people have that
All right.
planned out.
Any other last message you wanted to give out?
No, thanks for having me.
Yeah.
It was great.
All right. Well, thank you. We'll sign out.